Can we call the Human Services Committee meeting to order? Oh, do we have any courtesy of the floor? Was I supposed to go?
They don't sign up, you just ask.
Is there any courtesy from the floor? Hearing none. We have a report from Mental Health Early Intervention and Development Program Administrator. Oh, hi, Matt.
Hello, how you doing?
Good. Hello, old friend.
Thank you.
My bad.
Hello. I'm Tiffany Rossinice, the Administrator for Mental Health Early Intervention Developmental Programs. This is my first time speaking in this division. I've been in this position now 7 months. Tonight we're going to have, I'm going to speak about mental health, and then I'm going to have the deputies from Early Intervention and Developmental Programs kind of speak on their individual programs for you. Overall, we are almost fully staffed, except for EI, but we're hiring.
Can I just ask, should we close the door? I'm sorry, and because I don't want to chase them away, but I want to hear you.
Whatever works.
Thank you.
Okay. So we are, as I said, we're almost fully staffed except for early intervention, but that's almost up to speed, and Jess will go over that when she talks. What I've really been working on is looking at the 3 divisions, the processes we have in place. I think something I always say is, don't come to me and say this is how we always did it. I just don't like that. So we're looking at all 3 divisions, what we do, how we can do it better. Some things we have to keep the same, but if there's an easier way to do something, services that we need to add, that's what we need to look at. We shouldn't just fund the same things because that's what we've always done. Fiscally, we are full staffed, and our fiscal officer is working on updating all our process that we have in place just to ensure that we continue to be in compliance with all the state regulations, federal regulations. So we're on a good path right now, just to kind of change things up and make sure we're doing everything we need to do. So I've been asked to speak on mental health, and there's a lot going on in the mental health division, but what I want to focus on tonight is our forensic programs. I'm not sure if you're aware, but we wrote we call it a grant, but it really isn't a grant. It's actually an annual amount of money that we're going to get every year for these programs, and the state had put out a request for proposals in response to the ACLU's lawsuits against the state, and it was about people with mental illness who are languishing in the jails on wait lists to get into the state hospitals, and what can we do as a county locally to kind of alleviate some of that. So what I gave you is one of the things the state did was they had a study done, and this is the results of the study, and it talks about reducing incompetency to stand trial and give suggestions for what it could be done at a local level. And we based our proposal off of that. So the first thing that we're doing is we've hired a dedicated crisis intervention trainer. She's also going to coordinate all the trainings with the local law enforcement. We've done many trainings. We've trained all the sheriffs here. We're going to be offering, they're working on it now, we're going to be offering 3 trainings coming up, and then we do the 6-hour training first, and then we survey those that we train, and we offer them to come back and say, do you want to do the 40-hour training? And then when they're done, they get a certificate that they're CIT trained. We've seen a lot of success in the community with the officers that have gone through the program, and I think last count Brian gave me, we trained over 375 officers since it started. So that's why we felt this was an important piece that we wanted to dedicate some money to. The next thing we're doing is we took one of our CRRs, which is a community residential rehab, and it's located in Bethlehem. And what we did there was take 4 of the beds and we made them forensic beds. So we've increased the staffing that is there. We've increased the training so that they have staff that are specialized in forensics. And that was it was a pretty easy thing. It was just a matter of hiring staff. They are almost complete with that, and we'll be able to start making referrals, I'd say, within the next few weeks. So that was another one that we've actually done, and it's been pretty easy to get started. A third thing we did was we've added, we call them forensic beds, but they're actually rental subsidies. And we are working with Conference of Churches, and we've added 11 rental subsidies for the forensic population. Conference of Churches will accept the referrals. Could be from the jail, from mental health, community partners. They're going to do the search to work with landlords to get leases signed. And then they'll also work with the individuals to get them the necessities they need to get set up in their own apartment. So that one is actually started already, and that's going well. And again, it's going to be working with our staff in tandem so we can make sure that they have their therapies and all the other necessary things, but the housing piece this program will take care of. There's a pot of money that we put aside for treatment for anybody who's determined to be forensic. So they could be coming from the jail, they could have been involved with probation, they could have had criminal justice. We've actually sat down and decided what is forensic as a group, and we're training our staff on that. So we know kind of who to refer to, who to authorize, and then we have that money available for treatment services. There is an RFP that we just released on Friday, and it's for a Justice-Related Services Boundary Spanner Program. So we call it JRS, some of us call it Boundary Spanner. It's basically as a individual that is going to be the liaison to people coming out of the jail who need to know how to get a doctor, get a psychiatrist, who do I call for treatment, just the basic, they're almost like a navigator of services in the community. They're going to work with our forensic case managers to kind of pull everything together. This person, the way we wrote it, can handle up to 50 individuals. If we see a need to expand that at some point, we can always try to go back to the state and add to that. But for right now, that's our goal, is to hit 50 individuals.
And how long does that service continue, like from exit to maybe a month or 2 out, or?
It really is going to depend on the individual. It could be to a point where they get their therapy, they have a doctor, their psychiatrist, they're pretty much set up. Our forensic case managers is checking in with them. We might say, you're good, you don't need the boundary spanner. We might link them to peers in the community. It really is, it's going to be individualized. That we haven't put a time frame on. And the final piece, which is going to be the biggest piece, it's the most challenging for us to put together, but we're actually really kind of having fun figuring this all out. It's called an Outpatient Restoration Long-Term Structured Residence. We refer to it as an ORLTSR. I'm actually learning all of these acronyms as I go. We currently have an LTSR. It's an 8-bed facility in our county. It is designed for anybody stepping down from the hospital. It's a very structured environment. This is the same concept, except this is going to be specific to forensics, and it's designed for anybody who's in the jail who's deemed to be incompetent. Our goal is, instead of, a lot of times when they're found to be incompetent, they're either sitting in the jail or they're on a wait list to get into Norristown. Instead of depending on the state hospital, what we're looking to do is bring them to this facility, and our goal is to restore competency so that they can stand trial, they can be stepped down. We don't want anybody languishing in the jail. We want to make sure that we're getting treatment. So we are looking, we've did an RFP. We have selected a provider. We thought that was important, that they can be in on all the discussions and the planning. And now we're doing kind of two things at once. We're trying to locate a location. We hope to keep it in Easton because it's in proximity to the jail and probation, the courthouse. That's our goal. It is also going to be a locked facility, so we have to look at, you know, any kind of challenges that come with that. But as we're doing that, and the provider's really the one that's going to landlord with the facility, so they're kind of seeking out where could we make this happen. We are going to be working with talking to the courts, the district attorney's office, probation, pretrial, to say, how is this going to work? How can you refer to us? What can we do? There's a lot of pieces. There's not much as far as guidelines for an OR LTSR. We have LTSR guidelines. We've asked questions. The state really doesn't have much because there aren't really many facilities like this. A lot of other counties are out there trying to do this as well in response to this. So it's our goal was July 1. That was our dream goal. Now we're looking, hopefully, the end of the year, but realistically, it could be the beginning of 2020. Just because we don't want to do this wrong, we have to do this right. And there's a lot of key factors that we have to look into. If people aren't doing well, what are we going to do with them? We don't want to just keep dropping people back at the jail. So we need to really look into that. So that's our biggest project right now. The forensic, we've just been working on nonstop. And we're just going to continue until we get them all up and running. Yeah. So that's my focus right now for mental health. Does anybody have questions?
Yeah. A question is, and I know locally we're not the only county, that counties are coming together, DAs, judges, human services, realizing that the prison situation in mental health is just untenable. It has to be resolved. And I think even Ccap has pushed this, I believe, for over and over again. So my question is, the state has given lip service to this for years. Do you get the sense that public welfare, and through your associations, the Department of Public Welfare, is actually serious about this? I mean, as opposed to just saying, yeah, you know what, it's a problem and we got to do something about it. Is there anything changing there? Because the counties, I think, have been on this thing for a long time now, understanding that this is just ridiculous. What is it? Is it changing the culture in the state?
I would believe so. I mean, it's the discussion topic that we are having everywhere. The fact that they actually put out this proposal to the counties and said, here's what we need, what can you do? And we really didn't challenge what we requested as far as funds. So I think they are taking it seriously, and I think that other counties, it's just now it's going to be trying to get these programs that are very intense and for a population that is kind of tricky and get them up and running locally. I think that we're all kind of doing this as we go, so the rules are kind of a work in progress. But to me, the fact that they released this and the amount of money that they are giving out to the counties and that they're guaranteeing annually, they're not saying, we'll get you started and then good luck, fund it yourself. I think that's a really promising step.
Thank you.
I just wanted to point out that later this evening we have a resolution supporting Ccap's priority, and this is in fact Ccap's #2 priority. So it is an important issue, and when the Allentown State Hospital and institutions like that closed around the state and for the country for that matter, the folks that were in those institutions didn't go away. And unfortunately now we're seeing it manifested either in the nursing home or jail population. You mentioned the issue about establishing a place. Now what we've learned, those of you that were here for the prison issue, or the jail rather, zoning is a hot potato, and nobody wants this anywhere near anything. Have you had any discussions? You said Easton and West Easton, I guess, would be an option as well. Have you had any discussions with the local zoning officer and investigated any potential sites, and what hurdles would we have?
We are very aware of zoning as an issue. I can just, on the drug and alcohol side, when NET went up against zoning, I witnessed that. We're not naive to it. I haven't personally had discussion, but I know that the people that there have been talks with, that the provider has talked to, they're familiar with zoning and the challenges. So I think everybody's aware, and we know going into looking at locations, we have to keep that in mind, because obviously if we don't have a location, we're dead in the water. But we're going with the positive that we actually had providers bid on this RFP when many counties, nobody even jumped in. So we're looking at it as we got that first hurdle, and we're going to be very positive that zoning and the community are going to accept everybody, but realistically, we know that's our biggest challenge.
Okay. Well, thank you for your work.
Thank you.
Anyone else? I just want to hear more about the CIT in the future, because when I was at Ccap, there was a program presentation on that, and that seemed to be the most effective use, is that having somebody in the community to work with the law enforcement folks really reduced the amount of people that actually even got to the crime level. So I'd like to see how that progresses. I think that's promising. So thanks for doing that.
Yeah, and our dedicated trainer is actually going to focus on the police departments that haven't sent anybody, and we're going to look at making sure they're educated on what it is, and hopefully that will encourage them with a one-on-one contact to send some officers, because it's a great program. I'm going to go through the 6-hour one when we have it next.
Is there anybody that they've dedicated in any of the municipalities or cities that, because what they talked about at Ccap also was not just the training, but they had a dedicated person to work with the officers, so sort of like a mental health specialist along with them to help
we don't have
make
anything,
linkages and...
Yeah, currently we don't have that, but I think the way that Brian has worked, he has a good relationship with the chiefs, and he gets to know the officers that come through. So they're given a lot of resources and contact information at the county level that they can contact us, and we can figure out where they need to go and who they need to work with.
Okay, great, thank you. Good job in 7 months.
Thanks. I'm trying.
Now, my understanding is we had to make a switch. Somebody needed to go. Okay, that's fine.
So this is Wendy Novak, and she is our deputy developmental programs administrator.
Hello. We are currently serving 1,039 individuals in our department. We serve people with intellectual disabilities.
Oh, could you just say your name again for everybody? She introduced you, but
Wendy Novak.
thanks, sorry.
Okay. All right, so our eligibility now is individuals with intellectual disabilities, individuals with autism spectrum disorder, and children with developmental delay. And then I thought I'd go over our major responsibilities. Our current, I would say the biggest one is managing all the funding decisions. All the decisions that we do make regarding our funding is based upon need and availability of funds at the time. Our fiscal department is wonderful. They keep track of the dollars. They let us know what we can spend, how much we can spend, and it's been a very good relationship with them, so we're very, very happy. We have two primary funding sources, and one is the federal government. We have what are called the waiver programs, and currently 638 of our individuals are enrolled in the waiver programs. There are 3 different types: person-family directed support waiver, community living waiver, and consolidated waiver, and they all have different dollar amounts. The one has a $33,000 cap, one has a $70,000 cap, and the other one has no cap. The way we handle that funding is the state gives us a certain number of slots, and then we based upon who's in an emergency situation, we look and make sure that all of those slots are filled. So at any one time, we keep those filled as best we can. The only time we get additional slots are in case of an unanticipated emergency. For example, someone's parents died and they needed a residential placement right away. The state would allow us to request a slot and then assign them to us. And the other way we get them is through state initiatives. And what the state will do is they will give us specific criteria for which those slots must be used. And during this past year, we've had slots given for 2018 graduates. 2019 graduates are coming up, and individuals that ended up over our $33,000 cap due to changes in rates and services. Okay, our other main funding stream is base dollars, and those are dollars from the state. We have different service definitions as to what the money can be used for. We have things like respite, home and community rehabilitation to get individuals into the community, increase their personal living skills, their communication skills, that type of thing. We have companion services for individuals that need some sort of supervision and there isn't anyone else able to provide it at that time. And again, this is the one where fiscal keeps track of the dollars for us. What I think is our most popular program and helps touch the most people is our family-driven family support service. It is a voucher program through Easter Seals. Once a year, families can request monies that they think they'll need for the year for things like respite, recreation, family aid, those types of things. And once the dollar amount is set, they are able to use that money in any way that they wish within our definitions. And that's a really helpful program because sometimes people just need a little help, a little break to help keep their people in their homes and be able to maintain taking care of their loved one. And we found that very effective. So some of the other duties that we have are service approval and authorization. Anyone who's open in our system has what's called an individual support plan, and that includes different skills assessment, medical information, financial information. It's looked at as a plan where if, God forbid, everyone who knows this person is no longer available, someone could pick up this plan and know what is needed to be done to support the individual. So when people are getting services, they are attached to that plan. And then what we do is we have to take a look at the services, make sure that they fit the service definitions, make sure that the dollars are available to pay for it, and then we are able to authorize. We also do new provider qualification for people that want to become an agency through the state. And we look at to make sure that they meet ODP requirements, including training, employee background check, and policies and procedures. And then building on that, we do quality assessment and improvement for providers based in our county. And that includes provider monitoring, in which we complete record reviews, policy reviews, visit sites, and actually interview staff and individuals that are receiving services to make sure that they're receiving quality services. We also do incident management, where we review allegations of abuse, neglect, medication errors, misuse of funds, law enforcement activity. In general, we interact with individuals and their families and providers as needed to assist with any concerns, service needs, that type of thing. We do intake, which we had talked about, developmental delay, autism spectrum disorder, and intellectual disability, and we determine the eligibility for the services based upon the eligibility bulletin provided from ODP as to what criteria people need to get into our system. That's the basics. Does anyone have any questions?
Well, it's a clarification. You do full lifespan services, correct?
Yes.
So birth to
Yes. Death.
heavy task.
That's a lot of diverse needs.
Thank you for the report. The respite care, I know, is vital. It's important. You touched on that, and I don't think folks sometimes understand what's all involved and how that helps in so many other areas. And you did say you have money for it, but what would you say is the percentage of folks who request respite care that we're able to fulfill?
that's a hard one to answer based upon different funding streams and how we get it.
But just overall, I mean, you don't have to, just in general. I'm not, it's not a test. I just was curious.
Most of our people are either in one of the funding streams. If they're in the FDFSS program, I would think if they need respite, based upon their allocation, they would be able to get it. It's kind of a hard question. We try to help as many people.
Oh, no,
as we can
I
with
understand that. Like, if, let's say, and forgetting the streams, because I understand, believe me, I understand how crazy it is with streams. But if your department or your area, let's say across the board gets 100 requests. Now, I know you're going to say, well, some streams we can do everybody, but just in general, would you say 80% overall of the people who ask for respite care relief, I need to get away. Could I please? I would like X amount, like day or 2 days. I'm just wondering, and if you don't, if that's a impossible question to answer right now, that's fine. I don't want to put you. I'm not putting you on the spot.
As long as we have money available, we try to make it, that families can get what they need.
Okay.
Unfortunately, we don't have unlimited funds to meet everyone's needs.
And that's what I guess I'm wondering. I mean, believe me, in human services, every division, I know the requests and the needs far exceed the money you get from the state, the feds, and certainly from the county. So I guess I'm asking in general, my question in general was in trying to get us out, because I know how important respite care is, how we're doing overall with that in terms of people who want it versus those that we can actually give it to, that regardless of where the money comes from. That was all.
I think we're doing pretty well.
Okay, good.
We might get a request for respite, and one of the caseworker organizations will come and say, okay, this is why it's needed. Please make this a priority, and we'll take a look and try to get whatever we can.
Yeah.
Can I add something to that?
Sure.
Not related to DP, trust me. One of the things that a plan we just submitted to the state for using our Health Choices reinvestment dollars is for respite care.
Okay.
And I know before Deb Nunes passed away, she and Wendy had spoken at least a little bit about this, but I certainly can't answer the question that you asked, Wendy. But in part, if the state approves that plan, we will be able to open that service up to even more folks, not just with developmental disabilities, but other areas as well. But that would be a larger pot of money over 5 years that we could add to that. So.
And the reason I asked that was, honestly, we never could fulfill the request, and there was a time when it was just horrible.
Right.
I mean, we were way back, and now and then I like to see if there's benchmarks. Has this changed?
Sure.
Has it gotten better? Has it stayed the same? And that's all I was curious about. But thank you, I appreciate that.
I have a question.
That's it.
So how do people access these services? Like, how do they come to you? Like a referral source? Or if
Yeah.
people are in the community that need you, how can they get in touch?
What they would do is call the intake and referral number and say that they want an intake for developmental programs. So their basic information would be taken, name, address, that.
And how would they even know that these services are offered? Like, is there any marketing or any sort of advertisement about this in the community? No.
The schools are all familiar with us.
Okay.
And they advise the families. We have been out at some transition fairs for the schools.
So the point of access is really schools, or
Or we'll have families that might talk to someone else that they need to come. We get a lot that way. We'll have people that move from other states that will call us and say, okay, what do I need to do to get hooked up with you? And then once they make that initial call, then their referral gets sent to our intake person. There's one person who is assigned to do our intakes. And then she will contact the families about what kind of documentation is needed to determine eligibility.
okay. Yeah, because I was just concerned about how people in the community know that you exist outside from, you telling us here. How
The
they
hospitals
access.
are familiar with us.
Okay.
That's a good question. I never really thought of it that way. So.
Okay. Maybe that's something that needs to be thought about a little bit more.
It's a more global conversation going on in human services at the moment.
Oh, very good.
Specific developmental programs.
Well, yeah, all the programs in human services, how do you access them? How do people know that they can access them or that they're eligible for them? I've met people in the community that ask me, where do I go for this? And I say, call the human services, see where they can hook you up. What department? Because even I don't know.
No, and it's interesting coming into the county from a private provider, because as a private provider, feels like all we do is marketing to,
Right.
So, when you come to the county, it's like, well, no, we're here to give the services, people just call us. And in large part that's true, but we have been having more sort of larger scale conversations about how do people find out about some of our services and how do they access them. And we're certainly in the community and doing different events and different things, not necessarily just for developmental programs, but so yes, that's becoming a larger issue. I would think doctors would also be a referral source for developmental programs as well. So,
May I addendum that?
Go ahead.
We used to, no, Sue,
Yeah, no.
please.
No, that's great.
Sure.
That marketing thing, just in general, we still do brochures that the Human Services Department, and
Yes.
it goes to like senior centers, it goes to, I think, some schools, it goes to wherever
I don't
people
know
may be.
where all they are sent. Probably about
Some doctor's offices will
yes,
have it, especially big practices.
about 6 months ago, I had asked each of our divisions to send me their brochures, and every division has one, and so it's a matter of, and they all have their own, systems of where those go and how they get distributed, but it's still something that we are going to take a look at, making sure we're doing a good job at that.
Yeah, because
So,
I've
good
had
question.
I've had a lot of people ask me questions about services for people in home with like dementia or Alzheimer's, and they're mostly the caregivers who are just kind of thrust into this situation,
Sure.
have no idea what they're supposed to
Absolutely.
do, and for whatever reason, they don't understand what programs they have access
Absolutely.
to.
Yep.
Can I
That's a very good
comment
point.
on that? Like the 211 system, the 211 system, like maybe tying it into that or something. I don't know. 'Cause that's kind
We
of
certainly can look into that.
that's
I
kind
don't-
of a go, but
Right.
that's another conversation for
No,
another
it
time.
is.
But yeah.
I take all suggestions.
Yeah.
But I think it's also a function of how good the social worker at the other end is, because we may have all these great programs here, and you may get a social worker that just goes, well, I'm not sure, you could try this, as opposed to someone who really handholds and directs and gets them to the
Right.
right door. So
Well,
I think
and
once
even-
they get to you,
Correct.
it's,
But you're-
Then they're good, but getting
Yeah.
those, and even ERs, the turnover and different things like that. I mean, we have our IRIS division, the Information Referral Division, and Children and Youth specifically do regular meetings with some of the folks from St. Luke specifically, Lehigh Valley as well, but not to as large of a degree, for this reason, to educate them about all of the services and how to access things in the county. But it's not obviously a once and done. It's always has to be done for the.
Well, yeah, because there's so many
Bosworth.
different pockets of people in
Correct.
different regions and in different socioeconomic planes, and they
Yep.
don't have access to everything. So it's how do you reach everybody? It's really difficult, and I understand that that's a
Correct.
monumental task.
Yeah.
But I just asked,
No,
where's like
that
the
was a
point
very
of
good-
entry?
It was a very good
Yeah.
question. It was a very good question.
do you feel that there's anything else you need to tell us? Or how, I mean, staff-wise, are you better than you were a year ago, or are you still have needs?
Well, we're still looking at our different duties and trying to figure out how we could best use the money for what positions. I think you have to take a good look at that before you go into I need this staff, I need that staff kind of a deal. So we're trying to figure out exactly what we need as things are changing in our system. I think our emphasis might change. So we're doing okay.
Thank you for your time today. Any other questions for her? I know you have a commitment. Thanks.
Thank you, Wendy.
And next is early intervention.
I say that they serve the best for last year because my name is Jessica Whiteneck, and I am the program director for the early intervention program. I've been doing that for the last 8 years. I was also a service coordinator, and I also came out of Children and Youth, so I've been in the Department of Human Services for a very long time. Speaking in terms of that, this program that I run is Tiff and I always laugh because we always say it's one of the best departments in the Department of Human Services. We work with children from birth to 3, and it's an entitlement program. So anybody from any economic base in the county of Northampton can call us and say, we have a concern with my child. Can you come out and look at them? And we say, absolutely. So it's a great program. If they qualify for services, then we put somebody in. The eligibility that we need, we do a standardized test, so there's certain parameters that we have to follow. So we do use a standardized test to make sure that they qualify for our services. And if they do qualify, then we put services in. Right now, I contract with 19 different providers that serve those children, and they are licensed physical therapists, occupational therapists, speech-language pathologists. We have vision specialists, we have hearing specialists, and we have educators that come in and help these children. We also have, underneath me right now, I have 2 supervisors, 11 service coordinators, and a clerical person, fiscal clerical person. So we are fully staffed at this point, and our numbers keep growing. So that's one thing that I always like to tell people, that our program, like what we were just talking about, with going out to the community, we have so much child find activities that we have so many referrals coming in that it's hard to keep up with that magnitude of referrals.
Oh, wow.
So we are definitely out there. People know about us, and we're a great program. Some of the numbers that I just want to tell you about, because I think it is significant for our program. When I started in 14-15 in this position, we received 1,454 referrals, and we served 890 kids in 14-15. In 15-16, we had 1,495 referrals, and we served 1,100 kids that year. So it dipped a little bit, but it was still high. And then in 16-17, we had 1,672 referrals, and we served 1,252 kids. And then in 17-18, we had 1,685 children, and we served 1,262 children. And what that means is that those served children actually had services in there, and the ones that were referred either didn't qualify or they eventually didn't qualify, and we had that many children. Our budget is about $3 million that I oversee, and that's base money. And then we also have medical assistance and waiver that helps support the rest of the services when those children have the medical assistance. It is entitlement, and it's free, so anybody that wants it can utilize the system regardless of the funding stream that they do have. I'm trying to think what else. So the children that we do serve, just so that you understand, is any child that has any kind of significant delay. So they might come in and they might have a speech delay, or they might have a motor delay, so they're not walking on time. They might have a feeding issue where they need just a little bit of help with some feeding. And then we also have those more significant children that will go on to developmental programs, which Wendy was talking about, that have cerebral palsy, Down syndrome, some of those more significant issues, mental retardation. We have a lot of children that are just being diagnosed with autism between that birth to 3. So we're looking at that. We have a lot of children that come in right from the NICU because they were born so premature that they are at high risk for developing a developmental delay. So we do monitor those kids. We also track some of those kids that have some of those qualifications but don't actually qualify for services. Our service coordinators will track them. Some of these kids will get the services until they're 3, and some might only get them for 6 months. So depending on the severity of their delay or their diagnosis, that's what really hinders their involvement with our program. We do help them transition to the next stage, so whether it is, our program ends at 3, and then the local IUs in each county does the 3 to 5 program, so they also have an entitlement program. They're more specially educated, so they're looking at more of school-based programs. We do help them transition through that process so to make sure it's smooth. Anybody can refer to us, so parents, we get a lot from the doctors, we get a lot from CHOP, we get a lot from the developmental pediatricians, hospitals, daycares, grandparents, anybody can call us to make a referral. Goes through our INR department as well.
You said that you're seeing an uptick in autism and premature births. To what do you attribute that to?
I think it's more, the autism part of it is just more parents are aware.
Aware.
That there's something.
So more diagnoses,
Yeah.
because there's more awareness to it.
There's
And,
more awareness to it. We can't diagnose, we're not a medical model, we're family teaching. So they come in and they'll say, my child has significant speech delays, and we go in there and we can tell that there's more issues. So we might say to them, yeah, if you have these concerns, you're a developmental pediatrician, this is kind of the route you go. But that 2 to 3 mark, 18 months to
Right.
3 is really a significant age where they're being diagnosed.
And the premature births,
It just depends. It's
that's not a consequence of the opioid crisis
That's
or
what I was
anything like
thinking.
that.
No,
That's
it's
what I was
See more of
thinking.
that.
it's so staggered that it just depends. I mean, my mom could have preeclampsia and she just
course.
delivers early, or yeah, I think the youngest we were just talking about, I just saw a 24-weeker who was not even a pound. She was 14
wow.
ounces, doing fabulous.
Wow.
Now, is at home, was in the hospital for 9 months of her life, and she's really doing significantly well.
Because
And
go
we'll
ahead,
put
sorry.
services in that will help her.
But you said that you track these children. Do you also track the numbers of, like, autistic kids that you serve in 1 year to the next, and like premature births and downs, and so that you can track trends?
Yeah, there's data reports on that for us. It doesn't really matter what your child has. We're going to serve them no matter what. So those
course.
numbers aren't as significant to me. It's just serving the children. It'd be interesting to see.
But are there trends?
The trends of them. I'm sure I could pull reports and actually look at that. But to me, I'm here to serve the
Of course.
kids and the family. So, yeah.
The only other question I have is, I know that there was a concern last year that one of the developmental daycares was going to close. That gap was closed. Someone did refund.
Yeah, unconditional childcare is a great program that was out of the CCIS, which is I think there's lots of acronyms, but it was out of a program that really helped with the funding for like Title 20 and childcare. Since the state reorganized that particular program closed. So the unconditional childcare actually came out of that, and what they do is they actually go into the daycare centers and they help those kids that don't qualify for our services but might need additional help. They were actually picked up by Pine Brook, so they will continue with services through Pine Brook. Yeah.
Any other questions? Go ahead.
Yeah, hi, Jessica.
Hi.
My question is, we're talking about children up to 3 years of age. So an autistic child, once they've passed 3, what happens if service-wise?
They would go to the IU. It's not just the IU. We also help them with, because the IU, what we always say is our program is not the end be all. So
Right.
when we have families that have diagnosis like that, we try to give them services in the community. So private therapy, there's P50 services, there's BHRS, there's those types of services for those kids that need it.
I mean, I know there was a time, autism, it was just at the state level, and in fairness to counties, the state, the DPW, your children and youth departments, sub-departments, and then the mental health sub-departments, mental retardation at that time, sub-departments, all would try to offload autism onto each one, saying, well, if it's a child, it's children and youth. We don't really know. We're not going to let it be called mental retardation. We're not going to let it be called mental health. Is that all, like, gone away by now? In other words, a state is willing to own it in terms of this is an issue, and it is in developmental programs, and it should be funded. The autism became something at one time, at least, that was batted around as to what is it. And frankly, in many cases, it was batted around as to not so much we're concerned about what it is we're concerned about which one of us has to pay for it in terms of services.
I don't think that's correct anymore.
Okay.
There's services out there for children. It's just trying to find them and locate them.
But I mean, through the county, though. I mean,
No, we have, well, I can't say for sure. For our program, we're going to help them with the services,
Good.
with the developmental delay, and then we help them with the other services that are out there.
Yeah.
What's happening now is that this DP side of it came in and said they had that autism waiver, and parents are confused by that. So we're getting a lot of phone calls about that, what it means, what can they use it for, and then we either redirect them down to INR, or we have them go to the ARC or one of those other bigger agencies that can explain a little bit more about what autism services are out there that's outside of the county, because there's only so much we can provide to them.
And I think if what I'm saying is confusing, you can imagine like the public, and I know it's always been the case in human services. And autism, I always felt bad. The county tried to do as much as they could for parents with children, regardless of their age, but it was very hard at one time. And I mean, I'm going beyond. I'm saying, let's say, we're talking about a 10-year-old mother comes in, she has a 10-year-old son, and says, he's autistic, and what can anybody do? And it tended to be, the state was like, and you were put in a position as a county human services department of, well, how do we, if we can't classify, that's our big thing. If you cannot be classified, you cannot be helped. And it sounds like we're getting better at that.
Yeah, the diagnosis is under DSM now, so there's a classification for it. It's the autism spectrum disorder. So you're not, Asperger's anymore. You're just on the spectrum, which helps a lot of families now get the services that they need, even outside of the county.
Well, thank you.
There's way more services now, I guess I could say, for the children that have autism and support.
And for me, it always went back to money. And the state, it sounds cold and hard, but the state was always looking for a way. We have X amount of money, so our first goal is we don't want to spend more than that. So how do we, and that goes back to Mr. Cusick with closing the state hospitals. Everything there'll be a fancy name for it, but it's all about how do we not spend as much money. And it sounds, though, like with what you have, you're doing a good job. So
I
I
think the
appreciate
gap
that.
has closed in.
Yeah, and I felt that at one time families with autistic children of any age were really getting the short end of the stick when it came to any kind of service. But now I'm glad to hear that that's not the case.
I think for what you're talking about, those children were diagnosed way later than the kids now are being diagnosed a lot earlier.
That's good. I'm glad to hear that. Thank you.
May I ask a question? You might have answered this in the beginning, but how long have this program been up and running? For the first, for the 3-year-old and under.
For the county?
Yeah.
The state, this program's been here since 1993. That's when it was implemented. That early intervention actually broke away from mental retardation. At one point, it was all right. Tiff, 1993?
Same thing,
1991. It was in the early 90s.
Okay, thank you. Yeah. Okay.
Yeah. It was just clumped into mental retardation, and then they separated as the program got bigger.
Yep.
And there was more money to serve more children.
Great, thank you.
It's a great program. It's one thing that we tell parents all the time.
You catch it early and straighten it out.
Yeah. There's lots of research and data on that.
Good.
The earlier you get the kids, the more successful they'll be.
Anybody else? Thank you, Todd. Thank you for your good work.
Hello again.
Hello.
I will try to keep it moving so Jen has enough time to do her thing. And she is under the weather a bit, so she asked that we bear with her. She's been a trooper waiting. Thank you, Jen. Happy New Year. So just a couple of quick things with Graysdale, and then I'll let Jen finish the rest. Last time I was here, somebody asked about the tuition assistance program, and I got the information from our HR person over there. And for spring we do it pretty far in advance because of when the applications are due to NAC. So for the spring 2019 semester, we had 3 applicants, 2 LPNs and 1 RN, and 2 were accepted into the tuition assistance program. The third was placed on hold simply because she was still taking prerequisites. So we met again in December to review applicants for fall of 2019. And this time we had 2 applicants, 1 LPN and 1 RN. both we have accepted, and now we have to wait and see if they are accepted into NAC. We do expect, I think I mentioned this before, that as folks start to adhere to the attendance policy that we are now enforcing, more folks will be eligible for the tuition assistance program. That was one of the prerequisites, is you can't call out sick all the time and take the old-fashioned 99 days that that folks used to take and still get tuition assistance. So, so I wanted to follow up on that. And I'm going to let Jen really give the details, but we had our annual survey with the health department in December, right around Christmas. And as you guys know, Premier performed a mock survey with us prior to their departure and felt that we were well prepared. This was obviously our last survey under Premier, and there were deficiencies, but Jen has all of the actual information on those, so I'm going to let her explain those, and then you can obviously ask any questions that you may have. So children and youth, I'm going to try to highlight a few things from each division that we didn't already cover, although one other thing I wanted to say, the CIT program that Tiffany talked about, there was an incident last month or the month before County Council when I was called downstairs. One of the deputies was dealing with a woman from the community who was very upset and had been experiencing some difficulties and has challenges herself. And it was amazing to watch the deputy work with her. I commented to him, and I knew that he had gone through CIT training by watching him, and he did confirm it for me afterwards. So it really is a fabulous program. Okay, so children and youth. I had to pull some data for Ms. Zembo, and so some of it, I got additional data that I wanted to share to highlight some of the volume of the work that you all already know we do. But from 2017 to 2018, our intake caseloads went up by 51%. It's just in 1 year. There was a 38% increase in cases that we accepted for service after an initial assessment. And one of the pieces of data I had to pull for the Ccap report was related to substance abuse related referrals for children and youth. So families who we receive referrals on because of something with substance abuse. We had 733 in 2017 and 1,195 in 2018, which I didn't do the math to double check, but I'm told is a 63% increase.
What year was that?
Say that again?
Say the numbers again, I'm sorry.
2017, it was 733. 2018 was 1,195. Tremendous. So, you know, we're in the throes of you know, not just the opioid crisis, but of course dealing with all of the after effects of that, and that will continue for a while. But some good news. I wanted to share just a couple of statistics from our Family Engagement Initiative. I know Kevin Dolan had been here quite a while back to explain this to you all, and essentially it's the agency coming together to find as many family members for each child that we get called about in order to, the hope is we prevent a child from coming into foster care. We keep them with either with their birth mother or father with family support, or place them with kin if they absolutely can't be with birth parents. So in 2018, the family engagement folks conducted 95 crisis/rapid response family meetings, which served a total of 175 children. 172 of those children were not yet active to children and youth when we got the call. Of those 172, sorry about that. There were 113 children that were in the home at the time that we held a meeting with the family. And of those 113 children, 91 were able to remain at home. 20 went with kin. Only one child was placed in foster care and one child was hospitalized. So just phenomenal work that those folks are doing. And that said, our placement numbers in children and youth increased by 25 or 30 in the second half of 2018. So even with all the amazing work that they're doing, there have been a lot of cases in the last 3 or 4 months that were just so clearly this child had to be placed in care, that number has gone up. We're hovering right under 300 youth in care. So, but the Family Engagement Initiative and those folks are doing excellent. I'm going to speed it up. I did want to just tell you, though, children and youth, because we've all those new positions we added in the summer. One of the questions was, if you can't fill positions, what's the point? So we currently have, in terms of caseworker 2 vacancies, we have 4. Caseworker 3 vacancies, we have 1, and then we have 1 social service aide vacancy. Those are all vacant. The caseworker positions are all vacant because the folks who were in those were promoted, and we have that 90-day right of return. So we have they've done an amazing job hiring a ton of folks, and obviously the only downside is those folks are still really training and getting up and running. So so that Jen has more than 2 minutes. The only other thing, I'll move the rest of
Well, I just want to take a moment of time.
Sure, go ahead.
Because we're at 6:13, we have to take a break before 6:30. So, and
Yes.
how much time do we need
No,
for Jen?
I'll only give you 1 more minute. I'll save the rest for next month.
All right, because I know there's going to be questions for her also. So
I only have one quick question for you. How's the turnover rate in children, youth, and families on caseworkers?
Well, it's probably better in 2018 than it was in 2017, and the fact that we have 5 caseworker vacancies, and you all created, probably 8 of those 13 new positions were caseworkers in the summer, I'd say we're doing pretty well, which is amazing. Now, there's always going to be turnover, right? So it's going to be a cycle, but no, they're doing great. So I'll save everything else till next month, except to tell you this billboard, which I didn't want to kill a lot of trees, is now on
I see it. seen
Route
it.
22, and there's 2 points that it is at. And the best part about that is, while we did get a significant discount for that advertising, it was actually paid for by the Bethlehem Health Bureau via a grant that they got, but had to contract out to spend. So we were really excited about that. Everything else I will save till next month.
thanks.
Maybe next month you should go first.
We won't have 3 or 4 speakers next month. We'll be good.
It's a big division, and we've waited a long time, so I appreciate that.
I did. I actually saw the billboard. Thank you.
Thank you.
This is the last one we're going to see, right? Should I start talking? This is the last we'll ever see of this. Because it's going to take a new format. She kept the premier format, and so it's going to take a new one.
Right.
Starting Jan.
I ended the year of December on their format, so it would be easy to
Consistent,
understand
yeah.
and follow through. But starting for January in 2019, for February, I'm going to redo it so it's more user-friendly, and you'll be able to see more information on there. So if we want to go over it a little quickly so I can get to the survey. Jennifer Stewart-King, interim administrator at Graysdale. The admissions, we were at 666 for the month. Target is 670. Usually in December, it does fluctuate and go lower due to families keeping members home over the holidays. January, February, we start to see more of an influx. Cost per day, you can look at the finance part of it, $234. Then you can go down to the Medicare reimbursement, $516.28. Nursing hours for the PPD, you can see how we've been trending up at 3.30, which is above budget, but we are working on that to get it back down to 3.20. But we actually have a lot more staff, so it's a good thing, but a bad thing because we're above budget. So we go into the survey on the back. So we had 2 surveys. So we had the Department of Health survey, which we had 11 deficiencies for that. This was the first time that we've ever had the new survey process. They got us in last November under the old survey, so we had to wait a year to see how this new survey proceeded. What happens is the Department of Health starts all their information while they're in their offices, so when they come in, they hit the ground running on the units. So there were 11 deficiencies. A variety of things. There's a new protocol for side rails, so if somebody wants to use a side rail, you must have a consent. We did not have consents on every person. We had 666 people to get them on. We did not have all of them. All our plan of corrections will be done by February 1st. We had things, we had 3 different aides feeding residents while standing, and they should be seated at a table, so it's more dining room-like. We had 2 issues with care plans. There was one where a psych medication was not listed as a care plan on the care plan, so that we got a ding on. Another thing on the care plan was somebody was supposed to have heel protectors on, and they did not, so they were on the table. So our staff development department is going through all the shifts, and they are retraining everybody. And they are doing audits. The supervisors and the charge nurses on the floor are auditing. The CNAs are also auditing themselves. They're going around and looking at different things. The other survey we had was life safety, and they're looking at the building. There were 31 deficiencies. Now that it's when life safety comes in, they're looking at 3 separate buildings because given the age of the main building, they are divided up into 2 separate buildings. The original building, the addition of the north and southwest sides, and then you have the tower building. So a lot of those deficiencies had to do with waivers that we have to prove every year and submit waivers for the tallness of the tower building being 10 stories and the age of the main building. There were doors. We have, I was quoted by maintenance to say about 1,000 doors at Graysdale. There were some doors that were 1/8 of an inch off. We have fixed it.
Wow, this was thorough.
Yes, very thorough. They did go to the penthouse, and there was some insulation on the ground. Maintenance just had to fix it. We have had 2 rooms that have paneling. We have to take down all the paneling down because although the side that you see is treated, the back side is not treated. But these are original to the buildings. So we have maintenance is working on that to take that all down. So maintenance, the life safety aspect will be done by March 1st because they came in after the Department of Health survey. I did want to let you know the Christmas was a success. Our volunteer office, instead of getting socks for everybody, they were able to purchase crossbody bags, and in those crossbody bags were all filled with all kinds of things. So it was a nice, instead of 1 socks, they got all different kinds of things for them.
Oh, cool.
Yeah, that was very, very lovely. Even on the dementia units, it was nice because they could walk around and just put things in. I did want to let you know we do have a new ADON that started. She was a supervisor. She came from Easton Hospital. Her name is Kirby Freeman. So she is a liaison now between the 2. She's still acting as a supervisor and learning the ADON. So we have now 2 ADONs and, of course, the DON. And I also want to let you know, Brian Dunlap, who is the lead accountant, is going to Marywood to obtain his NHA. So he will be assisting me, and he will be an administrator in training. One of the other things that we wanted to talk about was we are doing an RFP. It has been put out for a new electronic health record system. Well, the current system we have is 4 years old, and the company got bought out, and the company came in September, and off the record we were told that it's like we were just coming out of the box. So we still have paper charts. We cannot do certain things because their system doesn't allow it to do it. We've done workarounds, and now that they're updating their system, all those workarounds are being undone, and it's leading to a lot of issues. And it's a lot of compliance issues. We are missing med orders, so nurses have to compare what's on the screen with what is actually written. It's time consuming. We have admissions that take hours because the information, once it's put in, doesn't populate into all of the other sections. So they must, every assessment that they do, they have to put in all that information, re-put it in. So we did put that RFP out, and we're hoping to have some people interested in it.
I need to call time, so we have enough time. Does anybody have a question that they absolutely want to ask her? Because what I'm thinking is that maybe next month we could give Graysdale much more time,
Okay.
and then you could go a little bit more into.
Right, because we'll have more meetings with the RFP.
And we could also hear more about the survey and what your correction plans are, if that's, but does anybody have a question they really want to ask right now?
Is that a thought, like, because we're, on these committees, and I know it's presentation questions, but we get jammed, and if we don't really want to talk a lot at the council meetings, and we don't have time to talk at the committee meetings, why are we even meeting? So I would suggest that possibly Graysdale is such a huge topic, and I have questions, but not tonight, that maybe we could have like the director's report, because human services is huge, and then just put Graysdale on its own for a meeting. I'll bet you anything Graysdale could take almost an hour.
Well, it sounds
Well,
like
with
next
these
month
number of
that's what we'll
deficiencies,
do,
yeah.
but,
Okay.
you know, any other questions? Because I think the survey deserves a little more attention.
It does.
As we have time
But
for
we're
it.
transitioning.
Because I did hear it at the Graysdale meeting, and I think, you know, again, just to keep in mind, it's not the new staff, this is a leftover from Premier, and we could hear more about the methodology. So thank you for your time. Good luck in your
Thank you.
transition. Motion to adjourn,
I'll make it.
adjourn?
Yeah.
Thanks.
Said
I was
we're
like, I
done.
can't second that, but, yeah. Awesome.
Laura, look, that's just my general thing about us as council. It has nothing to do with any committee specific. We're jammed.
I just haven't